Welcome, everyone, and to this very special session. In recent years, we've had so many technological advances in the field of interventional cardiology, some of which challenge really the historical idea of permanent metallic implants were the way to go and the things and how we should be doing things for the future. But several advances have evolved in the field and made us challenge that notion and challenge our minds. Could we actually treat coronary artery disease without leaving anything behind, like permanent implants? Drug-coated balloons emerged as a very powerful tool in the armamentarium of interventional cardiologists and in the cath lab, and they surged really in recent years. Today, we're keeping it real, as they say, and we're going to focus on drug-coated balloons. The title of the session is Leaving Nothing Behind. I'm your host, Dr. Abdelhamid Al-Faddagh. I'm an interventional cardiologist at Jabir Al-Ahmed Hospital, and I'm absolutely thrilled to be joined by two of my colleagues. First, Dr. Professor Hussein Hishmet, who's a professor of cardiology at Cairo University and a practicing interventional cardiologist at Tadawi Group here in Dubai. And next to him is our great guest and special guest, Simon Ikshall, who's a consultant cardiologist at the Norfolk Norwich University Hospital in the UK, whose hospital practice and research focuses on major health issues in CVD, but particularly Simon has really pioneered the use of DCB-only approach in PCI. So welcome to both of you and thank you for being here. The objectives of this session is to talk about the practical considerations for choosing patients for DCB, highlight the use of DCBs in in-stent restenosis and de novo lesions, and understand the value of lesion preparation and recognize different types of dissections. We definitely want to acknowledge and thank our sponsors for this session, with whom which contribution this session would not be possible. Those would be ATC for B. Brown, so thank you very much for this generous sponsorship. And then the format of the session will be basically starting with two cases and then Dr. Ikshall's talk, and then we'll end with the discussion around those two cases. So Professor Hishmet, without further ado, the podium is yours. Thank you.
So good morning, everyone. I'm glad to be here. And as we are entering into the new era of leaving nothing behind, we'll start first by two cases that I chose from my practice. My practice now is mostly 70% DCB with a small proportion of stents, usually as a bailout or for very large vessels. So we chose two cases that I will present very quickly. I chose the cases that they got a lot of things. You'll see calcium bifurcations, in-stent restenosis, diffuse disease, a lot in the two cases. And they might be a bit provoking, and they might make some of us a little bit uncomfortable. So let's start by the first case. It's a 44-year-old gentleman. He's of Asian origin, hypertensive and diabetic. There is a past history of one drug-eluting stent that was implanted 1 year earlier. The patient has plenty of medication, so he's not always compliant to taking the dual antiplatelets. And then he presents with a high-risk non-ST elevation ACS. His ejection fraction is 45, and he has normal kidney functions. So we may leave the loops for a while so that you get a feeling of what's going on. The left main circumflex, the proximal LAD, the stent, and the lesion, which is distal to the LAD, with a probable thrombus involving a bifurcation. And there's no issues in the right coronary. His right coronary is fine. So if we focus on the real situation here, then two questions would come up. The first one is, what would be your primary intention device here? You would go focusing on stenting, drug-eluting stent, or you'd better keep your focus and your primary intention on a drug-coated balloon? That's the first question.
Probably by the raise of hands. So if we go to the first question, so what would be the primary approach of people here? So if you're in the drug-eluting stent option, please raise your hand. So we have a couple. Drug-coated balloons. Okay, couple. And a lot of people who are hesitant probably between the two.
So that's the first question. The second question Would you insist on doing imaging with IVUS or OCT or whatever is available in the cath lab? So one option, no need at all. Everything is clear by angiography. You see the stent, it's expanded, it's opposed, there's no new intimal hyperplasia.
Who chooses that scenario or that approach? Probably 1, 2.
And who'd say no? Stent failure and ACS, always imaging.
Couple of hands as well. 3, yeah.
You may change your opinion now after I show you that this is the result that we got after we did a 3.0 by 20 NC balloon dilatation of that distal lesion that was distal to the stent, just a nominal pressure. So again, you might rethink your options based on this response to ballooning. And we also did an IVUS, and whenever there's a stent failure, I prefer to do an IVUS. So I'll try to make it short. And this is the distal LAD. You see, there's disease everywhere. There's no healthy landing zone. And you will see as we approach the stented segment, you'll see that there's a gradual build-up of plaque into the LAD. Here comes, and you see the stent. The stent has definitely landed in a disease segment. So the stent that apparently looks fine, number one, the distal edge has landed in a disease segment. And as we move on proximal, you can see that the stent is a bit underexpanded, definitely. And the LAD is probably a 3.5 or probably a 4 millimeter vessel. And if you look carefully, we see some minor residual thrombi, if any, but the stent is definitely underexpanded. And try to look at the proximal edge of the stent. See, there might be some distortion in the proximal edge of the stent, but we'll continue the case at the end of the talk. Let's move on to the second case. I told you these cases may be a bit uncomfortable. So this is a 51-year-old male. He's hypertensive, diabetic, dyslipidemic. He got angina. He had an exercise test that showed high-risk features, referred for angiography, and with a normal ejection fraction, normal kidney functions. I'll show you the left system, but you see how extensive is the disease in the right coronary. And that's another view of the right coronary, and this is the left coronary, I'm sorry. Let's try to play that. It's clearly a bypass case, there's no doubt about that. Multi-vessel disease in a diabetic with reasonable distal target. Maybe the right coronary is not the best distal target, but at least the LAD and the circumflex are good targets. The patient has seen 2 surgeons, and he insistently refused surgery. So we agreed with him that we will do a staged procedure, and he must be ready for repeat revascularizations, because we know the drawback of multi-vessel intervention in diabetic is the repeat revascularization. So we started by the right coronary, and you can see with a 275 balloon, we see significant dog boning that eventually resolve with a high pressure balloon, 3.0 at 20 atmospheres. And then because of the diffuse disease and the calcification, we had to use a guide extension to deliver the NC balloon into the distal vessel territory. And this is the result that we got after vessel preparation. So we'll keep it playing for a while, and then we pose the questions. Based on this results and looking at this dissection, it's going to be a bit clear in the next slide. When you see that, then there are one of 2 options. Considering this dissection, I will stent them immediately. I don't want them to call me in the middle of the night because of an abrupt vessel closure. No, these dissections are non-flow limiting. If I stent, it's going to be a metal jacket, so I would leave them.
So let's do a quick poll. So option number 1, raise your hand if you fall in that bracket. 1 or 2. Option number 2, they're non-flow limiting, I'll use a DCB. A couple more hands there. I guess these cases are excellent for the discussion, so Dr. Ikshal will we're eager to learn all your tricks and tips about using that. So thank you very much for being here with us.
Thank you very much. It's a great pleasure and honour to be invited. It's lovely to see so many people here. It's fantastic that this is actually the second DCB session of the day already. And those are beautiful cases, and it'd be great to see how they finish up. So I'm going to talk to you about all sorts of bits and pieces to do with drug-coated balloon angioplasty. Those are my conflicts. So why do we not want to put stents in? So there's a very well-used slide that shows at 5 years in a big meta-analysis that you have a stent failure rate that just carries on going up at 5 years. This is 10-year data showing exactly the same thing. At 10 years, if you put a stent in somebody, there is no evidence that the stent failure rate is beginning to go away. So at 10 years, it still carries on. So why do you need a stent in the first place? Well, it was only really originally for bailout of balloon angioplasty. Then we discovered that bare metal stenting routinely for everybody reduced restenosis as compared to balloon-only angioplasty. Drug-eluting stents reduce restenosis further, but like I just showed you, you've got this continuous target lesion failure and particularly stent thrombosis rate that does not go away after a decade of that stent being in. If you look back at the original data, the meta-analysis of all balloon angioplasty against routine stenting shows although you reduce the restenosis rate, you have absolutely no impact on mortality if you stent everybody as compared to if you do balloon angioplasty with stenting only when absolutely necessary. So if you can reduce the restenosis in some other way, then maybe you don't need to put the stents in. So I've got a lot to cover. There's all sorts of things about how you do DCB and in-stent restenosis. I like to keep it very simple. You can image to understand what's going on. You have to do really good lesion preparation. And most people would still try very hard not to put another layer of stent in. What about in de novo work? Well, we published this in 2020. It probably will need updating in a year or two when a few of the big RCTs come out, essentially telling you that if you want to do de novo DCB work, it's all about optimal lesion preparation. You can use any of your normal lesion preparation tools, and what you're trying to do is get a good angiographic result. If you've got less than 30% recall, you have no vessel-threatening dissections, you can use a DCB. Otherwise, you bail out with a stent. So some of the data that's out there, there's increasing amounts of data out there suggesting that DCBs work as well as stents in all sorts of different scenarios. That's the small vessel work where most of this started, the biggest study being the B-Braun paclitaxel sequent please basket small 2 showing non-inferiority at 1 and 3 years, but there's plenty more data there. Large vessel studies, there is some data, and there's an awful lot more coming in the next year or two, which is why I think perhaps the next consensus document needs to be updated after that. I think the argument about is paclitaxel bad for you, which came out of concerns over the peripheral work, has been completely now put to bed by Bruno Scheller and colleagues who did a big meta-analysis. On the left of the drug-coated balloon, this is all paclitaxel-delivered work against balloon angioplasty, bare metal stenting, or drug-eluting stenting. So 4,500 patients, and as you can see, over time, there is a difference in cardiac death in favour of better outcomes with paclitaxel balloons than any other form of angioplasty. So we started doing de novo work in 2012, 2013. This is my conversion rate early on. The blue line is my DCB use, which is mirrored by my stent use. So this suggests a number of things about the learning curve, about how we do our angioplasty, how we look at dissections. That's me over the next couple of years, and subsequently I've carried on at over 90% of all my cases are DCB only. This is a pretty all-comers sort of hospital I work in. It's a big heart attack centre doing about 1,500 to 1,800 PCIs a year. This is my department over the next few years, so this is still 2015 onwards. We shifted to 50-50 DCB and stents for all of the operators across all of the clinical scenarios. In the UK, we're very heavily regulated, so we collect lots of data. So the bad news is you're filling a lot of forms. The good news is we then have that data that we can look at later. So this is 2015, so nearly 10 years ago. Everybody in the UK is at the top. They're putting in lots of stents. We're right down at the bottom. We're a complete outlier with hardly any stents by comparison. But actually, when we are judged by our 30-day risk-adjusted mortality rates. So for us, bearing in mind we're a big heart attack centre, this is where we should be getting our patients to survive at 30 days, just under 98%. If we were going to be a statistical outlier, we'd be more than 2 standard deviations better or worse. That's 2 standard deviations better. That was us. And we have to take everything. We're a heart attack centre. We're a non-surgical centre. So it's not as though we're just not taking these patients to the lab, because that would be seen in our risk adjustment. So the only thing we're doing differently to most people probably in the country is we're putting in less stents. So we've started looking at our data in a lot more detail. The ESC guidelines a while ago said all DCB work should have 6 months of dual antiplatelet therapy. Most operators work on 1 month. We identified 300 patients of a small cohort over a short period of time where we were sending elective DCB de novo work home with 1 month of dual antiplatelet therapy. We looked at 6 months. There was absolutely no harm to the treated lesion. There were a couple of non-target vessel MIs and a non-cardiac death, but the MACE rates related specifically to that vessel, as in the target lesion failure, was 0. So we've stuck with 1 month of dual antiplatelet therapy. We also looked at our day case angioplasty because we send lots of elective patients home the same day. We had a consecutive cohort of 100 patients that we phoned the next day and followed them up and routinely afterwards. 50% of those 100 patients were sent home with angiographically very clear dissections, and they were all fine. So the concern over acute vessel closure, if you're not stenting, doesn't seem to exist. A bit like Bruno Scheller and his meta-analysis, we also looked at paclitaxel or stentless PCI safety. What we did here was we again went to our elective cohort. So these are all people we're not expecting to save lives in, it's just for symptomatic reasons. We identified a large cohort stent only, a large cohort DCB only. None of them had had a heart attack, none of them had had a previous PCI, so we'd remove those confounding factors. So we're comparing first-time DCB, first-time stents. We propensity matched them, so they're as similar a group as we could get, 429 in each group. And as you can see, this is just mortality. One group is dying distinctly faster than the other one. Yes, it's the one with the stents in. So we then went on to look at some more of our more contentious cohorts. We've been doing left mainstem de novo DCB only angioplasty now for nearly a decade as well. We compared our stented de novo left mainstem against our DCB de novo left mainstem. There was no difference in overall MACE rates, but numerically every individual component was lower numerically, but not statistically, in the balloon arm. We've also been using DCB in STEMI now for about a decade. Here is some of our early-ish work showing with a cohort of over 1,000 STEMIs, 450 with paclitaxel DCB, just over 650 with drug-eluting stents, and at 3 years there's no difference in all the usual outcomes that you'd expect. Really importantly, there's no increase in unplanned TLR, as in early acute vessel closure, if you're only DCBing and not stenting in the presence of STEMI. So what have we learned? Well, first of all, it's really important to say there's no class effect with DCB. Every product must be separately validated. It works well, but only if you've got a product that works well and if you do good lesion preparation, and then you're relying on vessel healing and late lumen gain. So for us, when we shifted away from stenting everybody, we had to relearn balloon angioplasty. We had to relearn all about dissections. And what you're trying to do is get not much recoil, avoid the vessel-threatening dissections, and this will give you your best DCB result. So the way we approach it, it's slower inflations, lower pressures than maybe you're used to. We might go all day in the lab and not go over 6 atmospheres. If the balloon is fully expanded, take it out and have a look, because that might be all the work that you need to do. But if you need to do more work, a slow stepwise increase in pressure and inflation time can help. And then a very simple algorithmic approach, adding in all the adjunctive tools, all the way up to calcium modification, will work. So I avoid semi-compliant balloons because I'm lazy and I know that if it doesn't go up, I'll keep cranking it up, I'll get a dog bone effect and I'll wreck the vessel. So I'm aiming non-compliant balloons one-to-one angiographically with lots of nitrates on board. Higher pressure and long inflations if you need them. If your non-compliant is failing, then the threshold is quite low to shift over to a scoring or cutting balloon. And scoring particularly works very nicely for lots of recoil or up front in osteal bifurcation lesions. Any calcium modification or OPN balloon, for example, has been shown to be safe in the setting of de novo DCB work. The scoring balloons and cutting balloons that we use here, non-compliant Scoreflex and the NSE Alpha would be the majority of our work. We also use the Wolverine cutting balloon. It's more expensive, so we tend to use it when the others are failing. We only had the old version of the Angiosculpt, which we didn't really use because it was a bit too undeliverable. I gather the new ones are much more deliverable, though. Here's an example of us doing a DCB-only angioplasty. I like showing this slide because you could have another vote, as you just did before. You could say to people, who wants to put a stent in the LAD on the left? And usually half the room puts their hand up. You then say to them, who wants to put a stent in the LAD on the right? You would be struggling to find any reason why you'd want to put a stent in that. It is the same patient. So what about bifurcations? So if you want to do bifurcations, stenting makes your life much more complicated. There are a couple of ways that if you want to do a hybrid approach that you could think about it. Firstly, if you were never intending to treat the side branch and you're just stenting the main branch and then you have to rescue the side branch, you can obviously go back through that stent, open up the side branch. If it looks good, then you can just deliver a DCB. That's the only time you should be putting a new DCB through a newly deployed stent. If you'd planned to do the side branch as well as the main branch, then you can do lesion prep of the main branch, lesion prep of the side branch, DCB your side branch, stent across it, and then you don't have to recross afterwards. There's no then complicated kissing, etc., that needs to be done. The much simpler approach is just to DCB everything, of which there's 3 options. The first one is you're doing both branches, in which case you do main branch lesion prep, side branch lesion prep, side branch DCB, main branch DCB, because that's the most important vessel. If it all looks good, you stop. No need for kissing. It's all sequential. If you just want to do the main branch, and there's some osteal disease, there's now some beautiful work from Prof. Shin in South Korea showing you'll get late lumen gain in the side branch as a result of your main branch DCB. The worst sort of angioplasty that there is in bifurcations currently, the worst outcomes is 001. We try hard not to do them, but if we do them, then we do it as the bottom. You obviously wire both vessels, but then you just do lesion prep and DCB of your side branch, and you don't need to worry about geographic miss because the balloon can be back into the main branch. So what problems do you get with lesion preparation with DCB? Well, it's all the same as every other type of angioplasty, except we maybe deal with it a little bit differently. So the undilatable lesion, it's the same algorithm I said to you before, really, about gently stepping up through non-compliant to cutting to scoring to all the calcium modification tools. And you can do all of this and DCB can still be safe. Here's a short example of not really undilatable, but possibly. There's my non-compliant balloon, which is dog boning. There's my scoring balloon at low pressure. There's the scoring balloon at high pressure. You can see the way the wires have moved and the balloon's fully inflated. There's the result. What about recoil? Less than 30% recoil is what all the consensus documents and all the DCB RCTs ask for. This is your eyeball, it's not QCA. If it persists, then again, follow the same sort of algorithm through the specialist balloons. Here's a very brief example of tight lesion, the initial recoil after a balloon, then the scoring balloon, then a much better angiographic result. Here's a much more angry, bigger vessel with some thrombus. We started off with a small balloon, got a bit of no reflow. A bigger balloon still doesn't look great. So we're now with our scoring balloon. Low pressure, it still doesn't look particularly nice. High pressure, multiple inflations. We're taking the scoring balloon back, turning it around in the guide, putting it in again to change our scoring planes. It still doesn't look good. I'm a fairly persistent guy. There's 14 atmospheres again with a scoring balloon. There's the result. So we would call that DCB time. There's the balloon. There's the final result. And 2 weeks later, they were back because we needed to fix the LAD, and the right still looks good. So what about dissections? Most people don't really pay them any attention because they stent them all. And we don't really look at the angiogram as the result. But there's an old classification that's a bit complicated, or a new idea which really is that you either stent it or you leave it. So this is the old classification. Just to make life simple, essentially all of that lot at the top is safe. Most of the stuff further down probably isn't. If you're worrying about the difference between a vessel-threatening dissection and a simple one, here's us treating a lesion in the proximal LAD. You can then see after the balloon that further downstream then looks compromised. It's either spasm, but we've given nitrate, so it must be an intramural hematoma. Before we can get control of that by, for example, cutting it open, we've completely lost control, and bottom right, you need to put a stent in. Some of the dissections you can leave. This is in the proximal LAD, the nice type A dissection that over the next 6 months heals. There's another one again in the proximal LAD that's healed at 6 months. There's a typical type B in the mid-right. If that contrast clears from that line next to the main lumen, then that's also fine to leave. If you're worried about what I mean by contrast hanging up in the vessel, this is a distal right coronary artery. We've been treating above that for stent failure and de novo disease, and there's now a dissection that's tracking down the vessel. So you can see contrast in the distal right all the way through this angiogram. So you can then just take your foot off the pedal, put your foot back on the pedal again a minute later, the contrast is still there. So that's contrast in the wall of the blood vessel. If that's not clearing, blood can also get in, and if that doesn't clear, a couple of hours later, they'll be back in the lab. You can see in the second view how it's beginning to expand around the whole vessel and give more compromise. For some reason, I still can't remember, we broke our own rules. We didn't fix this. This is what happens if you don't fix those. 3 hours later, it was occluded. The good news is they're relatively easy to wire as compared to acute stent thrombosis. The wire just sails down the main vessel, and it was fixed with a stent. So, dissections. Type 1, they're safe to leave. Those intimal tears I just showed you, you need TIMI3 flow. You can have some luminal compromise, and as in a bit of recoil, but it mustn't be progressive, as in it mustn't look worse over the next 2 to 5 minutes. The contrast needs to be clearing from any dissection plane. So obviously the opposite, the ones you need to stent, big spiral dissections that you'll see a mile off when you're doing an angiogram, but reduced TIMI flow, contrast in the wrong place that's hanging around, and progressive luminal encroachment. These are the ones you need to pay attention to. So how to manage dissections? You avoid them by doing very careful lesion preparation. You recognize the ones that are safe to leave and the ones you need to do more to or you need to stent. So you need to manage those uncontrolled or vessel-threatening dissections. You can modify them, change them back with cutting or scoring, or you stent them. So we have a checklist that we run for all of our cases now in 3 parts. You talk about lesion preparation. Is the vessel big enough? Have you given enough nitrates? How much recoil have you got? How deliverable are all your balloons? The safety aspect, which is how's the patient, the most important bit. What's the ECG like? And then angiographically, you want the TIMI3 flow, no progressive luminal encroachment, no big vessel-threatening dissection, the sort of horrible ones I've just shown you, and look for that contrast. And then the last bit is about delivering a DCB. It needs to be 1-to-1 compared to your largest lesion preparation balloon, which should be the same as your vessel size angiographically. And you need to know the transit time and the delivery time as in during inflation. I'll leave you very briefly with that. We've got a 2-day meeting in London in July, if anybody is interested, all about how to do DCB. Thanks.
Wonderful. Thank you so much, Professor Ekshel. Let's join me here in the discussion, and then we'll have Dr. Hishmet kind of present us through the 2 cases and what happened through them. And we might kind of pick your brain through the cases and understand exactly your take on some of these. And by the way, we do have microphones for any questions, so they're situated at the corners of the room over here. And obviously, if you're in the front row, we can provide you with a microphone as well.
So we're back to the 2 cases. If you remember, the first one had a stent that looked angiographically fine, but when we did the IVUS, we found that the stent distally landed in a disease segment, a geographic miss, and there was some query about the proximal edge of the stent. And we got a good result after an NC balloon dilatation. But considering the sizing that we got from IVUS, we went for a 4.0 NC balloon to make sure that the stent is expanded all along the way. We did a small balloon dilatation, NC balloon, to the diagonal branch. We didn't do any kissing. And you see how the proximal edge of the stent looked like. Initially, we thought that we did it, but we didn't, because we never recrossed. We went in the stent with a loop, and the IVUS went in. But it seems that the stent was under-expanded from the original implantation 1 year ago. And that was not seen by the plane angiography. You had to do stent optimization tools and imaging to understand why the stent looked that way. But after a 4.0 NC, now the proximal edge is fine, and the distal edge is fine. And we can see that by intravascular ultrasound. You'll see now that we still have the disease distal to the stent, of course, but the vessel lumen is bigger. And the stent also got a bigger diameter. It's much more expanded now. And also the proximal edge has been corrected. So at this stage, once we corrected the under expansion, the proximal and the distal edges, then there's no point in reusing another stent in a bifurcation. It's going to be 2 layers of metal across the bifurcation in a patient who's not always compliant to dual antiplatelets. So we used a 4.0 40 millimeter DCB to make sure that we spanned the stent, a clear safety zone proximal and a clear safety zone distal, and this is the final result. So, yeah.
Let's have you kind of ask through the microphone just so that everyone can listen to your question.
What was your logic for choosing a long DCB for this case? Because during IVUS, we saw that there is no edema inside the previous stent, and there was just undersizing and under expansion. I want just to know what was the logic for choosing a long DCB.
Yes, because the other alternative would be just putting a short drug-coated balloon at the distal edge of the stent. But the counter-argument is, whenever you inflate a balloon, especially aggressive ballooning as we did, then there will be some injury to the vessel, and the vessel will react with an inflammatory reaction. So the aim of the drug-coated balloon is to inhibit that inflammatory reaction as time goes on, so you prevent neointimal hyperplasia in the future. It's not to get an extra lumen, but to prevent the inflammatory reaction down the line.
Well, one question, I guess, that arises in these situations, and from Simon, your talk, you emphasized a lot on lesion preparation. Can we talk a little bit about kind of the use of imaging and kind of like preparing lesions, especially if they're like ISR lesions, like this case here? How often do you kind of ensure that you, for example, have a good IVUS or a good OCT image there prior to your DCBs?
In ISR, I'm still a bit of an outlier. I don't image a lot. I know I should. Even so, if it's ISR, generally, I find that the answer is either you've got a lot of neointimal hyperplasia, in which case you need to be very aggressive with your lesion preparation before your DCB, or the stent is too small, in which case you need to be very aggressive with your lesion preparation. So, although I understand the idea, and we certainly learn from it, we've actually looked in some of our early data, we looked at our first 350 ISR cases, we imaged in about half, we didn't image in about half, and it made no difference to our outcomes. And I think that's because we've already learned you need to be very aggressive in ISR. But you do learn if you image. You certainly learn, for example, if this is your case previously, it's really important that you get as much feedback for yourself as an operator, what you should have done better the first time, as well as fixing it the second time.
Definitely.
So yes, I'm still an outlier, I'm sorry.
Dr. Hashmet, any thoughts about kind of using a DCB for the side branch?
Yes, ideally I should have used a DCB, but when you operate in a world that's governed by DRGs, and then your hands are a little bit tight. But I would also like to take advantage of the data that Dr. Simon talked about, and I'm aware of that. When you put a DCB across a bifurcation, the drug that you release is not only released in the main branch, so it's also part of it, at least a little bit, is released into the side branch. So we know from OCT, from, I'm not sure it's Korean or Chinese study, probably Korean, that there is the phenomenon of late positive remodeling does not only happen in the main branch, but it also happens in the side branch. So that might be an advantage. So that drug-coated balloon that you use for the main branch will also have some favorable impact on the side branch.
Great, excellent.
So the take-home messages here, unlike Dr. Ecclesall, I would like to image whenever we have stent failure. For using a DCB for in-stent restenosis, you need to correct first the mechanical causes of failure, and then you put the DCB, especially at the edges. And the advantages, of course, there's less metal, less thrombotic tendency, and you preserve the side branches. Speaking of our patient who had this dissection in the RCA, of course, I didn't stent him.
Yeah, let's look at this image again. It's quite impressive, the amount of
dissection, yeah.
extraluminal contrast that we have here. Just kind of take me through the thought process of like, how do you guys decide whether to leave this or not? Honestly, I mean, it gives me palpitations looking at this. And
I told you, these cases are designed to make us uncomfortable. Basically, two things. Forget about A to F. You'll never remember them in a cath lab. I look at the flow. If it's TIMI3 flow, then it's good. If, again, I remove my foot off the pedal and press again, if there's persistent staining of contrast, it means there's a false lumen that can accumulate and compress the true lumen. If it's TIMI3 flow and there's no contrast staining, then I'll leave it.
Do you have any data kind of regarding these kind of dissections? Seems like it goes all the way down. Again, it might be also kind of a different approach to these kind of lesions. What do you have done similarly or differently in this situation?
Certainly, if they're very diffuse, I can't remember which balloons you used, but we would have used scoring balloons to try and give us the best chance of the most lumen gain, and then any dissections you get will then be longitudinal and more controlled and therefore not vessel threatening. But in fact, you've ended up with exactly that anyway, longitudinal dissections. So these are sort of extensive type B dissections, I think I'd call them, as long as the contrast is clearing.
So we went along and we used a DCB, and then the patient was discharged on the next day. We kept him overnight, and then we brought him back 2 weeks later for the stage PCI of the left system, and you can see the results pre and post on the left side and on the right side. And we didn't use any stent. DCB for the proximal LAD, DCBs for the circumflex. We'll show them again. And then we said, let's take a control angiogram. The patient didn't have any chest pain all through the 2 weeks, and his ECG remained the same. So after we did the left, he said, let's take a look at the right coronary. And on the left is the time at the index procedure, and on the right is the follow-up. You don't expect that the sections would heal completely in 2 weeks, but at least in those 2 weeks, it didn't extend. There was no abrupt vessel occlusion. We even see some tendency to healing of the dissections compared to the index result. So these are my conclusions. You need to prepare the vessel well. Here we used open high-pressure balloons, and non-flow limiting dissections are okay. They actually facilitate the drug penetrating into the intima media. They heal with time, and they promote positive vessel remodeling. And of course, no one likes to put a metal jacket. Thank you.
Excellent, wonderful. So we have 5 minutes for a couple more questions. Gentleman in the front.
Thank you very much for your nice presentation. Can you use DCB as a bridge for CABG?
As a bridge for...
see a complete revascularization?
Well, I think the question has two aspects. You would be worried about putting a stent because that would entail a long duration of dual antiplatelet therapy. So definitely DCB is an attractive option when you need to shorten the duration of dual antiplatelet therapy. And the other aspect of the question, you don't want to put a stent in the place where there's a potential distal anastomotic site for a lima or a vein graft. Again, DCB is a very attractive option in this regard. Yes.
Okay, thank you.
I have a question here.
Oh, a question over there. Go ahead.
Always you are concentrating about non-flow limiting dissection. This is wide term. It is not precise. Sometimes we have a 99% lesion in the LAD, and still it is non-flow limiting. And that it is TIMI-3, you mean a TIMI-3 flow, this is the non-flow limiting? Because it is,
Well,
to me, it is a vague. Sometimes we have severe critical lesion, and it's still non-flow limiting.
Yes.
But the patient is symptomatic.
Yes.
Don't you think that the FFR is more reliable way to pull your wire and take the patient out from the cath lab in these horrible dissections?
Yeah, so that's an interesting question. So a dissection with a positive FFR at the end.
Well, using FFR in the DCB era is still not very clear. But if you are worried and you're still not very confident of the DCB concept, and you need to make sure of the distal flow, and then you use the FFR, and it's 0.8 is the cutoff. If it's more than 0.8, I think that would be reassuring. If you're still not convinced by the eyeballing of the TIMI-3 flow or the frame count or whatever.
Simon, any
So
thoughts?
there is some data, it's not randomized, but there is some data suggesting that as long as you make, whichever sort of physiology you're working with, as long as you make that vessel non-ischemic on physiology, and that it doesn't then deteriorate over the next 2 to 5 minutes again, then that is a stable dissection. So Antonio Colombo is very keen on the concept of avoiding a full metal jacket in the LAD by using pressure wire guided angioplasty. Any bits then that after really good lesion preparation either have the sort of dissection he doesn't like the look of, and or a dissection that measures with too much of a resting gradient, he will stent it. And there's other data showing that as long as you make them non-ischemic, when you then follow them up, that pressure gradient will be less because you're getting late lumen gain. Mm-hmm. So there's two different aspects. From the point of view of safety of dissections or not, I think we're talking about the same sort of concept of TIMI-3 flow, not much luminal compromise, and then it's the contrast and big spiral dissections. But the sort of things we've been showing you, I've shown you the really nasty ones. The others are all non-flow limiting to people that have spent a while looking at angiograms. You can add in pressure wires, and in the optimal lesion preparation slide I showed at the beginning, it actually mentioned FFRs of over 0.8. You can also use intravascular imaging, and that's probably more to see that you've got enough lumen gain, because I think we're probably still, as a community, better at judging the safety of a balloon-only angioplasty result on an angiogram than we are on intravascular imaging. But there's lots of work being done, and there's lots of very keen people trying to work out how we can then use intravascular imaging as well to help with the safety aspect. So it's ongoing.
Maybe a small point to add on the physiology. You'd better then, if you insist on doing physiology, then you'd better use your physiology wire as the workhorse wire. Because if you now use the workhorse wire, and then you have a dissection, and you need to do the physiology to make sure is it flow limiting or not, then you will rewire in a vessel that is already dissected. So there is a chance that the physiology wire, which is not very maneuverable, goes into the dissection plane and makes your life worse. So that's a point of caution with physiology.
So the only thing I'd add to that is actually you get beautiful feedback in real time if you leave a pressure wire down connected and work on another wire, because then you can see exactly at each point during your lesion preparation what it is that you've done that's made that vessel non-ischemic. So it's beautiful feedback for...
So you use the two wires?
Yeah.
We have a very limited time, but maybe one more question.
Although it's not related to your to the cases you presented, but I want to ask a question related to better understanding of the concept of the DCB, which basically means that you deliver a certain dose of a drug to the intima, hoping to prevent later proliferation of cells and formation of restenosis. In cases of STEMI where there is a thrombus interlaying the space between the balloon and the intima, or in cases of calcification, how you expect that the desired dose of the drug is delivered to the intima?
Perhaps a very short
Yeah,
answer.
that's not a short answer. So if there's a large thrombus load, we don't complete the procedure with either a DCB or a stent if we can help it. We give the patient dual antiplatelet therapy, restore flow, bring them back after giving them 2B3A inhibitors for a day or two. A lot less thrombus, a lot easier to treat. I've shown you our STEMI cohort. The balloons work as well as the stents. TLR rates are always higher in STEMI cases, and I think that's partly because it's the most hot angioplasty we're doing with the most thrombus around. Calcification, very briefly, there's one study showing TLF rates are higher if there's a heavy calcium in the setting of DCB. In our own work that we're hoping to publish soon, we've shown that heavy calcification is worse for stents or DCB, but when you compare between stents and DCB and heavy calcification, TLR rates are slightly better in stents, but not statistically. Target lesion MI is much higher in stents as compared to DCBs and calcium. And if you've done good lesion preparation, you will get the effect of the drug.
Absolutely, and what a good ending kind of statement from that. So thank you very much, everyone, for being here with us. We're definitely going to see more of DCBs along the years and hopefully kind of continue to grow our practices in general. Dr. Akshel, Dr. Hishmet, thank you very much for being here. And thanks to our sponsors, ATC and UBAM, for this kind of sponsorship. Thank you.